Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Thank you so much for listening to Behind the Knife. This is Patrick Georgioff. I want you to imagine this. It's 2 a.m. and you're rushing a hypotensive trauma patient to the operating room for exploration. Maybe you need to go into the neck, the chest, or the abdomen. Are you prepared for what you might find? Trauma educational resources are extremely limited, and that's why we created the Trauma Surgery Video Atlas. 24 challenging scenarios with high-yield text, beautiful illustrations, and stunning professional-grade video that walks you through the approach and management of devastating injuries in a step-by-step fashion. Check out the link in the show notes for more. There are group discounts available as well. Now, enjoy the episode and dominate the day.
All right, guys, welcome back to Behind the Knife with the EGS team at Tiger Country at the University of Missouri. I'm Rushabh Dev, and I'm one of the acute care surgeons at Mizzou. Today, we're going to be tackling one of the most common EGS consults across the country, small bowel obstruction. But we're not just going to be talking about management here. We're going to be going into and providing a good journal review on the global evolution of small bowel obstruction and some of the predictive models that are out there dating from 2011 through the current practice in 2025. We're also going to talk about how some of these international studies can apply to North American acute care models across the nation. But before we get started, let's go ahead and do some quick team introductions.
All right. Hi, I'm Raymond Okeke. I'm the ACS and SECM fellow.
My name is Ezra Fletcher. I'm a third-year general surgery resident.
I'm Bryson Ratcliffe. I'm a fourth-year general surgery resident.
I'm Eugene Ismailov. I'm one of the PGY5s at the University of Missouri.
Awesome. So we're surrounded by a bunch of budding acute care surgeons who are nerds in their fields. So let's go and talk about the lineup. So we're going to walk through 5 major papers that influence how we can diagnose, risk stratify, and manage small bowel obstruction in 2025. So the first paper is going to be the impact of operative management on recurrence of adhesive small bowel obstruction, published in 2020 in the Journal of American College of Surgeons. Second paper is going to be the STRISC and NOFA scores for predicting immediate surgery or failure of non-operative management, published in 25 by the Oxford University in the British Journal of Surgery. That third paper we're going to talk about is evidence-based, cost-effective ACS algorithm for SBO management. This one was published in the Journal of Trauma and Acute Care Surgery most recently in 2025. The fourth paper will be discussing the prospective validation of a multivariate model for predicting operative needs, published in 2011 by the Journal of American College of Surgeons. And then the final paper will be the new clinical severity score for predicting bowel ischemia, which was published in 2023 by the International Journal of Surgery from the University Hospitals of Geneva. Quite a bit of papers that we're going to go through. We're going to do our best to keep it brief and get through the salient major points, okay? So, Dr. Fletcher, why don't you go ahead and start us off with the 2023 new clinical severity score? What's essentially the essence of this 12-year Swiss cohort?
Yeah, absolutely. Okay, so this was a single center prospective cohort study. They kind of compared this new data with old data from within their same institution. So this looked at 492 patients with adhesive small bowel obstruction from the years of 2008 to 2016. Basically, 70% were managed surgically and 29% were managed conservatively. They compared this with previous years from 2004 to 2007 and come up with this 6-item score. Basically, the main outcome that they looked at was small bowel resection as a surrogate for ischemia and necrosis. We're going to talk about 8 predictors that they kind of focused on. So age greater than or equal to 70, the first episode of a small bowel obstruction, no bowel movement or obstipation within or equal to 3 days, guarding on exam, CRP greater than or equal to 50, transition point on the CT scan, and then lack of enhancement on the CT scan, and then also about 500 mils of free fluid seen on the scan. To score these, each variable was worth 1 point. They used a threshold score greater than or equal to 4 to define, quote, high risk. This showed a sensitivity of about 65% with a specificity of about 88%. So why does this matter? How does this apply to clinical application? So scores greater 5 through 7 had a 100% resection rate. A score of 4 had about a 70% resection rate. And then if you scored 0 to 1, it was negligible at about a 0 to 6% resection rate. Also, in contrast to this, they kind of took into consideration different patients that were unable to receive IV contrast. So they created the 7-item no contrast score, which is basically the above the points that I listed minus a CT contrast enhancement study. The threshold, again, greater than 4, corresponded to a greater than 70% predicted risk. The same sensitivity, a higher specificity. Also, I think that especially applicable for residents because we don't have a lot of time to walk around and remember all 8 items. They kind of made a brief 4-item score. Age greater than 70, abdominal guarding on exam. You see a clear transition point on the CT scan, and then also that greater than 500 mils of free fluid on the CT as well. If a patient had a high-risk threshold, which is score greater than 2, out of this 4-point score, they had a greater than 70% predicted risk of resection.
That's insane. So, when you finished doing all this and reading this paper, what are some of the key clinical findings beyond the score that you thought about?
Yeah, for sure. So I think we can talk about operative versus non-operative strategy. So 70% approximately of the index small bowel obstructions were managed surgically, which was higher than many North American series as this was performed in Geneva. About 30% of all small bowel obstructions underwent resection. Recurrence for these, it was highest in the conservatively managed group, about 30% versus 15% in surgically treated without resection, and about 8% in those treated with resection. Interestingly, a prior small bowel obstruction doubled the risk of recurrence, and then the surgical treatment of the index episode halved the recurrence risk. To talk about complications with this, the overall post-op complication rate was about 35%. Complications were more frequent and severe with resection versus no resection, which is kind of common sense. And then, for me, most interesting, the traditional go-to labs that everyone loves to talk about when we talk about bowel ischemia or small bowel obstruction, lactate, leukocytosis, creatinine, and platelets were not independent factors of resection, and these were actually dropped from the study. The CRP number that they got that I mentioned earlier that was greater than 50, it was an independent predictor, but it was acknowledged as nonspecific, and we don't use it here, so it's not routinely used everywhere.
It's cool listening to you talk about this and kind of, reading ahead. And for the listeners, we're going to be hitting a lot of points, and a lot of things you said are going to be mentioned multiple times in all the different studies. So it kind of actually gets goosebumps going on the back of my neck, or maybe that's just the nerdiness in me. But I'm looking forward to kind of, tying it all together at the end here. So why don't you tell us some of the strengths of the study?
Yep. So I think for this study in particular, it was a prospective data collection in the developmental cohort. There were clear clinical meaningful outcome, meaning that we know what small bowel resection means. It's a hard endpoint for surgeons. It correlates with clinically significant ischemia, even if it's imperfect. There was both internal and external validation. So they used a relatively large cohort, about 500 patients, validated based on their internal reflections from the previous years. They did use multiple usable score versions, so they have an 8 or a 7 or a 4. These are more applicable depending on real-life constraints, so renal insufficiency limits your ability to get IV contrast sometimes. Also, the exclusion of malignancy, hernia, radiation, it creates a more homogeneous population, so this was true adhesive small bowel obstruction. And then they contextualized within the existing guidelines. So they compared their score to the Bologna WSES guidance and AAST small bowel obstruction severity classification. So authors explicitly compared their scores to Bologna and the WSES guidance, and as well as AAST, a small bowel obstruction severity classification. And then the data supports that timely surgical management for adhesive small bowel obstructions actually reduces recurrence as well.
That's crazy. You got way too many strikes, man. So why don't you tell us some of the weaknesses?
Yep. So single center, just one place. Their operative threshold for adhesive small bowel obstruction is actually higher than North America and ACS centers, about 70%, which, why does this matter? This can inflate the prevalence of ischemic bowel and actually overestimate the score performance when transported to lower intervention environments.
Cool. All right. Well, I don't know if this is a good spot to say it, but this podcast might be a little bit longer, but I think it's worth delving into some of these topics. So I'm just going to, preview the readers about the next few papers that we're going to go into. But regarding this last paper you talked about, overall great framework, not really a full plug and play kind of system to adopt at the U.S. acute care surgery model because of the CRP and that routine use of enhanced CT protocols. But still, the common points are that lack of that transition point, lack of small bowel enhancement, and free fluid as universal red flags. So with that being said, let's just go ahead and dive into our next paper, the Strisk and NOFA score model. Dr. Okeke, why don't you get us going on it?
Right. So this Finnish multi-center prospective study looked at 481 patients and actually produced two models. The STRISC is the risk score that predicts strangulation, while the NOFA predicts non-operative failure. They had two clinical questions that they wanted to look at. So the first one was, in adults with CT confirmed adhesive small bowel obstruction, can we actually predict strangulation at admission? And then amongst patients initially treated non-operatively, can we predict failure of non-operative management within 30 days? The study was a prospective observational multi-center cohort. Both had both internal and external validation, and then they were stratified into two cohorts, development and external validation cohorts. The patients that were included were adults with CT confirmed adhesive small bowel obstruction, as well as any relative clinically relevant labs obtained at presentation. For patients who had surgery within 30 days, who had IBD, intraluminal obstruction, peritoneal carcinomatosis, paralytic ileus, or were younger than 18 years of age, they were excluded from this study. If strangulation was suspected at any time, emergency surgery was pursued. Otherwise, patients got NG tube decompression, IV fluids, a water-soluble contrast challenge, with failure or new strangulation signs triggering surgery. The goal of this, is important to mention, was not to make another fancy score, but rather something that was clinically usable, well calibrated, and had real-world reliability. So starting off with STRISC, it looked at 6 variables. One of them was the number of prior small bowel obstruction episodes, then abdominal guarding, neutrophil to white blood cell count ratio, small bowel feces sign, the presence of mesenteric edema or free peritoneal fluid, and then a closed loop configuration on CT. I like to talk performance here because I think it's good to show that this is a very outstanding prediction model. So the development and external validation came out at 0.86 and 0.91. And if we look at 1 as a sign of perfect discrimination, this is actually pretty good for a prediction model.
Well, that's a lot of stats, man. So what does it actually mean clinically?
Thanks for asking that. So STRISC essentially... Listen, I like being nice. It's okay. STRISC essentially tells you, so how worried should I be that this patient is strangulated right now? And then they did more stats here, and they created an online calculator, which you can find in our show notes if you want to access that. But the patients were stratified into 4 groups based on risk. So you have a low, which is less than 5%, moderate 5 to 20%, high 20 to 50%, and very high, which is greater than 50%. So in this very high group, most of them ended up in the OR and required resection. So this is the patient you don't want to leave on NG decompression overnight. Now, speaking of NOFA, it actually reuses the same exact 6 variables, this to keep it simple. But instead, the question here, the outcome was, will this patient fail non-operative management within 30 days? Also had pretty good discrimination here, and it's actually pretty valid in itself. NOFA answers the question that we have when patients present on day 1 or day 2. So is this patient actually going to get better with non-op management, or are we just delaying the inevitable? So it helps reduce prolonged, unproductive, multi-day non-operative trials.
Yeah, so does that actually, that's probably one of the best parts of the paper that I enjoyed the most, seeing how they were able to create that model with the same scoring system. That dovetails pretty nicely with going into the strengths of this paper. So why don't you tell us a little bit about that?
Right. So strengths of this paper are it's prospective, it's multi-institutional, it's externally validated. Adhesive small bowel obstruction was the only population studied, so that's clear. It employed high-quality blinded CT review. It had good, strong calibration and a good discrimination. And again, there is the presence of the web-based calculator online. That's about as rigorous as EGS literature gets.
Yeah, it's pretty cool. I've already made it a home screen app on my phone. Then again, I have everything as a home screen app. Tell us about the weaknesses.
So, unfortunately, this study was conducted in Finland. So, practice patterns may differ from the US. CT interpretations here were by expert radiologists, not surgeons. Only adhesive small bowel obstruction was studied. So it doesn't apply to malignant, hernia, or post-op obstruction. And it's very important to mention here that prediction is not the same as a mandate. So even though STRISC and NOFA can help guide decisions, they should not and do not replace surgical judgment. There's a slide over prediction in the high-risk groups, but again, none of these things invalidate its clinical usefulness.
Yeah, I really like the paper. I thought this one was more applicable than some of the older models because the inputs are things that the US hospital systems routinely kind of collect already. And the CT-based variables match modern radiology practices. So kind of very reproducible, actually.
Behind the Knife would like to thank our partner, Jomi. With over 300 high-quality, expertly narrated surgical videos, Jomi is an indispensable resource for residents and students to prep for the OR. Attendings and residents from Stanford, Harvard, and Johns Hopkins depend on Jomi's up-to-date, peer-reviewed cases. Virtually scrub in at jomi.com to improve your OR prep today.
But anyway, let's go ahead and move on with the next paper with Dr. Ismailov. Why don't you go ahead and talk to us about the impact of operative management on recurrent adhesive small bowel obstruction?
Sounds great. We've been talking a lot about dead and dying bowel, so let's talk recurrence. This current study says that, adhesive SBO, as we all know, is pretty much one of the most frequent things we see in the emergency department in the middle of the night, middle of the day, and any and all hours. Historically, the dogma has been that if you operate on a small bowel obstruction, you risk developing more adhesions, potentially developing further episodes of SBO, versus if you don't operate and you're able to manage the patient non-operatively, this will be safe for long term. But until recently, we haven't really had much data on this, and the subject has been rather poorly understood. The current study I'm presenting leverages a unique statewide data set in Tennessee that links patients across every hospital in the state, so if somebody were to recur later at a different institution, they would still be captured in this data set, which I think is huge. The authors took adults with first ever adhesive related small bowel obstruction between the years of 2007 and then 2009 and followed them all the way to 2016 to watch for recurrences. They had about 6,000 patients and 70% of those were managed non-operatively. A median follow-up was about 10 years in each group, which is a pretty good time frame, I would say. They used pretty much a gold standard model called the Anderson-Gill model for analyzing recurrent events to see how the small bowel obstruction episodes and its management affected future episodes. They found a couple of things that I think are important and important takeaways from this. First and foremost, they found that operative management actually reduces risk of recurrence. So if you operate on a small bowel obstruction at its initial occurrence, you significantly reduce the chance of the patient developing another episode down the line. Skipping some of the math here, about 70% reduction rate in future recurrences compared with patients that were managed conservatively. The second big thing that they did find is that surgery actually delays the next episode of recurrence by many years. The operative index episode median was about 729 days to recurrence compared to 550 for a non-operatively managed patient.
So just over 2 years, right?
Yeah,
That's crazy.
it's quite a bit of a difference for sure. However, some negative things about operating, as much as we all like operating on small bowel obstructions, recurrence begets recurrence. Whether treated surgically or non-surgically, once a patient has a recurrence, their future risk rises with each episode, and the hazard ratios here for a non-op recurrence is 1.18, and for an op recurrence is 2.3, meaning if you're on your third small bowel obstruction, regardless of which treatment you received previously, you're much more likely to have a fourth. And then finally, as we all know, surgery does come with higher risks in the immediate postoperative period. One of them being mortality. For operative is 3.7. For non-operative patients is 2.6. I imagine this is during their admission with small bowel obstruction. And the complications are higher across the board. So whether we're talking about cardiac ischemia, pulmonary emboli, pneumonias, kidney injury, or wound infection. So ultimately, the reason why we're all in surgical residency is to make clinical decisions. And the trade-off is ultimately real based on this study that surgery does lower future small bowel obstruction episodes, but it does increase short-term morbidity and mortality.
Sweet. So tell us about the strengths of the study.
Yeah, so there's quite a few. The first one is that it's large, it's statewide, and it being all a linked hospital system, the authors were able to capture recurrences across multiple institutions within the state. Long-term follow-up approaching close to a decade. Appropriate recurrent event statistics, not just the first recurrence of SBO. They continued to follow these patients for this period of time. And they looked at clinical outcomes that we're all on the lookout for. So recurrence, time to recurrence, mortality, and then the associated complications that we've discussed. And then ultimately this was in Tennessee, so I think this has high applicability for ACS practices across North America.
Yeah, and then those are great strengths, but cluing into the limitations, there's one big limitation that I was listening to or kind of picking up on, and that's the complications associated with the operative cases. Why don't you dive in and tell us a little bit about those limitations?
So I think the biggest limitation here is that all of this is administrative data. We don't have CT findings. We don't have lactates. There's no clinical severity markers. We ultimately don't know why the patients that got an operation were operated on, which adhesions were encountered, whether the operations were laparoscopic or open, whether there was any bowel ischemia found at the time of the operation. Also, confounding by the indication is huge. Sicker patients are more likely to be operated on and more likely to have complications and mortality. This inflates the observed operative mortality, as you would expect. And finally, the data are from 2007 and 2016, which I think with the developments in the radiology world, I think the modern CT-based scoring systems, the standardized Gastrografin protocols, and as well as laparoscopy ultimately weren't as widespread.
Nice, nice. Good job wrapping up that paper. Let's move on. We're almost at the end, okay? So, hey, Bryson, are you ready to go?
Yes, sir.
All right, man. Let's finish off and wrap us up with the JTAC's EGS algorithm.
Yeah, so Journal of Trauma Acute Care Surgery algorithm is the most North American document in the group. It pushes a structured approach. This paper answers the questions we all have of what's an evidence-based, cost-effective way to manage small bowel obstruction actually works in real-life ACS practice. All right, so this synthesizes moderate evidence, including CT predictors, previous guidelines, including East guideline, and other meta-analyses. This algorithm starts by emphasizing the CT scan as the central decision-making tool. Like Eugene had said, we move beyond the era of relying on plain films, non-specific labs, white blood cell count, and lactate. CT tells you the anatomy, the transition points, and most importantly, the early signs of ischemia. So, importantly, this paper lists the features that strongly predict the need for urgent surgery. Most importantly, like Desiree talked about previously, mesenteric edema, free intraperitoneal fluid, a closed-loop obstruction, lack of small bowel feces sign, and bowel wall hypoenhancement. Like I said, same findings as they found in Zielinski, Strisk, and NOFA scoring systems earlier. The message is clear. The CT is predictive, it's reproducible, and it should guide your decision-making. All right, so according to this algorithm, about 20% of small bowel obstructions need emergency surgery right at presentation. These key triggers are peritonitis, hemodynamic instability, CT signs of ischemia, and a closed-loop bowel obstruction. The authors are crystal clear on this if you have one of these. That you should not delay surgery for a gastrografin challenge or prolonged observation. You need to go straight to the operating room. The important part is the non-operative management of adhesive small bowel obstructions. Without emergency surgical indications that we talked about, the algorithm supports an initial trial of non-operative management. This includes your NPO, NG decompression, your fluids, and your early T reassessment. They shifted away from the old dogma that the virgin abdomen always needs surgery. This paper shows and cites multiple places of evidence that the adhesions are the most common cause. With no prior surgery, many can still be managed conservatively. This is a huge point for the residents. The authors strongly recommend using a water-soluble contrast study, Gastrografin challenge, within 6 to 24 hours after NG decompression for these stable patients with adhesive obstructions. Why? The evidence consistently shows it shortens the length of stay, it predicts failure in non-operative management, it provides diagnostic clarity, and it avoids prolonged, pointless non-operative trials.
All right, cool. Good job, man. So, what do you think the algorithm's biggest clinical push is here?
And this algorithm talked all about the Gastrografin challenge. They strongly recommended using a water-soluble contrast study between 6 and 24 hours after NG decompression in stable patients with adhesive obstructions. Why? The evidence consistently shows that it shortens the length of stay, it predicts failure of non-operative management, it provides diagnostic clarity, and it avoids prolonged, pointless non-operative trials.
So why don't you tell us a little bit about the important nuances of it?
Yeah, the real value is predictive. If contrast reaches the colon, then it's a good sign. If not, then your patient likely to fail non-operative management. The authors emphasize you should not delay the Gastrografin challenge beyond 72 hours. That's when you see the morbidity of delayed surgery that goes up.
Nice. All right, so while we just dive into the biggest point that I know all of you guys as budding acute care surgeons want to talk about, so what about the role of laparoscopy?
Yeah, so this is one of the strongest contributions of the paper. It analyzed the modern role of minimally invasive surgery in bowel obstructions. They used randomized trials, meta-analyses, and NISQIP data that shows the laparoscopy is safe, it's effective, and is associated with shorter length of stay. And it's definitely best for single band or simple adhesive obstructions, but only in the right patient. The ideal candidates are less than 2 prior laparotomies, single band obstruction, no diffuse peritonitis, and the bowel diameter is less than 4 centimeters. This mirrors current North American minimally invasive surgery practice, especially at high volume centers for laparoscopic and robotic acute care surgery teams.
Nice, man. Good analysis, good review. Great job going over that. It's the current standard to bill from everywhere in acute care surgery services nationwide. So should be building local protocols, if, in my opinion, to mirror this kind of information that marries the CT findings, nasogastric tube decompression, water-soluble contrast, and these timing-based red flag triggers. We've gone through quite a bit. It's been a bit of a journal club. I think all of you guys have done a great job, but I think we should probably start bringing it all together. Yeah, so I want to remind everyone, a lot of what we have heard today and gone over actually started way back in 2011 with Dr. Zielinski's prospective multivariate model. One of the papers that we didn't fully discuss, but I want to clue into a little bit because it sets the framework or it helps tie in everything that we've discussed today. It was the first serious attempt to bring objective CT-driven structure to outline this notoriously murky disease process we have. And after reviewing these papers from Switzerland, Finland, the new US models, and these consensus algorithms, it's remarkable just to see how much has changed, but also kind of to realize how much has really stayed the same, looking at the same things just with different models. And you can see across every era and with every healthcare system, there's just one key message that to me I think keeps resurfacing. It's the surgeon's job to identify strangulation early and before the bowel declares itself and not after. I think that's one of the key points, right? Zielinski's original work showed that just 4 features, obstipation, mesenteric edema, free fluid, and the absence of feces signs, could meaningfully stratify patients which were heading towards the OR, which I think we've done a pretty good job fast forwarding now into 2023 and 2025 with the Geneva score that expanded the concept by integrating clinical labs and CT findings, this Finnish Strisk and NOFA model in 2025 that returned to mesenteric changes like free fluid, the feces sign, or lack thereof, the number of prior small bowel episodes as most reliable predictors, and then this all got tied together with that Teac algorithm that just came out, right? And it kind of talks about the same features and the foundational knowledge of those red flags on the CT scan that determine whether or not you should be proceeding for early operative intervention. For me, you sit back and we listen to these journal clubs and we ask ourselves, what does it all tell us? Despite more complex stats, multivariate modeling, all this bootstrapping and external validation, the same core imaging features that mattered in 2011 still matter today. Our tools have just only gotten better, right? We have better CTs, higher quality imaging. Our methodologies are tighter. Our access to laboratory data and quick access point of care evals are much more improved. But the biology of strangulation hasn't changed. It's the same biology, right?
Yeah, so there are 3 big shifts we've seen now, which are pretty interesting. So we've gone from operating early to operating selectively, but earlier when you should. So the old mantra of don't let the sun rise or set on a small bowel obstruction has actually given way to a more modern mantra, which is don't delay when high-risk features are present. Also, we've seen that there's no single lab, no single CT cut, no single vital sign will save you. Modern scoring systems acknowledge what seasoned surgeons already know. Small bowel obstruction severity emerges from patterns, not isolated findings. So it's whether it's Zielinski's 3-feature or 4-feature model, Geneva's 8-item score, or the Strisk NOFA 6 predictors, the shift is towards integrated clinical models that reflect real-world decision-making. And then finally, the long game is important. Recurrence matters. So again, operative management in the first episode decreases long-term recurrence. Non-operative management has lower perioperative morbidity, but earlier and more frequent recurrence. And each episode, operative or non-operative, raises the risk for future recurrence.
All right, dude. So where does this all leave us in the Teac country and across North America? After 15 years of models, validation studies, and international data sets, I'm pretty sure we can distill this into 4 clinical truths that surgeons can bank on. So number 1, CT predictors are at the heart of SBO decision-making. I know that kind of burns a couple of my senior partners, but I'm going to say, across every paper in every country, the strongest predictors of needing surgery include mesenteric edema and or stranding, free intraperitoneal fluid, closed-loop transition points, a lack of small bowel enhancement, and or the absence of a feces sign. And number 2, the physical exam, which honestly, in my humble opinion, is the most important, still matters, especially guarding and the delineation of an obstipation history. Guarding and obstipation appear repeatedly as significant predictors in all the studies, from Geneva, Zielinski, to Teac. Everyone talked about it. And if a patient has both, objective CT red flags and or guarding with persistent pain and no foul movements or flatus, you should seriously consider expediting the OR and not another gastrografin challenge or another day with the NG tube because you may aspirate. Number 3, failure of non-operative management is predictable and or preventable, right? The Strisk and NOFA score reminds us that non-operative failure doesn't occur randomly. It's predictable, and you can get an idea from when these patients arrive in the ER. Those with high neutrophil to lymphocyte ratios, multiple prior SBOs, mesenteric changes, and there it is again, the fecal sign being present or absent in the setting of guarding and obstipation gives you these predictive models. And if the patient arrives like this and they have those elevated scores and you use that calculator that's on your home screen, I hope it's on your home screen, the odds of non-operative success drop dramatically. So instead of repeating imaging and prolonging that NG tube decompression, these are the patients where early operative intervention improves outcomes, decreases costs, and decreases length of stay. So all these things, right, at the end of the day, these are the contributions that we never had in 2011 at Zielinski's first framework, which I think is pretty cool. Moving at the end, above all else, remember that SBO isn't just one disease, it's a spectrum. I think that's one of the biggest things that we could take home from this. Your job is to figure out where on that spectrum your patient's going to lie before the bowel makes the decision for you. So, from all of us here at Tiger Country and at Mizzou, this is Behind the Knife Acute Care Surgery team signing off and reminding you to trust your exam, trust the CT, trust the red flags, and when in doubt, operate before the bowel asks you to. So until next time, stay sharp and
Dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.